result and outcome of our group is all of the 5 leaking eye achieved leak-free right after the procedure. The end result remained after 6 months follow-up, and no recurrent noted in both early and late onset leak. We have both better bleb morphology, unchanged visual acuity, and IOP control with no medical glaucoma medication. So this is safe procedure, simple technique, good result. No regress have been noted, no major complication, and we achieved better bleb morphology. Thus, no other author before us do the same. But however, our group is very small. It's just a 5 eye, leaking eye. So we look for the same paper in the PubMed that we found no result has been done about this technique in the PubMed. So we hope that we will conduct, we will do have a bigger, we have a further study with a bigger sample to affirm the result. So with the needling and autologous blood, we hope that we will provide an autologous treatment to put one more choice on the table for glaucoma especially. And thank you for your guidance.
Thank you, Dr. Zhang, for wonderful presentation. Very nice picture and nice video. Also, it's wonderful. It's still a lot of doctor here. Yeah. So, is there any comment or question from the audience? So we can see the technique. It looks quite simple. We use only 1 liter, 27 milliliter, and we make blood. We make bleeding, and then there's no more leaking. And for all 5 patients, we have done. So, any comment or question from the audience, from the doctor from glaucoma department? I just wonder, as from the video you saw that you use a needle to make bleeding, right? And how much is enough for bleeding? Can you tell us what is enough? So it make the whole area of the bleb become black, or half of that, or more than that?
Actually, we haven't precisely in the amount of blood we need to put over the scale of blood, but as much as you stop, as long as you stop the flow,
the leakage.
The leakage, yeah. Because as the common last Friday, if you want to leaking to seal, you need to time to stop to buy time to stop the flow. So blood pass acting like a temporary block the leak side, and the aqueous humor don't go through it anymore. So that's why the conjunctival epithelium go into and seal and do the thing like they seal go in and seal the lip.
Yeah. Among your case series, there are 3 cases. We have a leakage for the first day after the surgery, right? So very early. Why would you check it? For example, find the cause of the leaking, such as a loose suture, scleral suture, or conjunctival suture, to check first. Why you choose needling like the first choice? Why I ask you that question? Because you know that if there's a blood on the wound, and the scar will develop quicker and stronger than there's no blood. And it also not good for blood, because the blood cannot allow the aqueous humor go out, right? So it's sometimes it's not good. So why you choose that like the first one?
As I mentioned in the talk, that all 5 patients has been to has been tried with the conservative treatment, like we use medication to avoid tumor suppression. We use a bandage soft technique, but none of them work. So if you it's low conjunctival, for example, as you told me. So what you do for the patient, we put the patient on the OR, right? It's still your gains, right? So the rate of scar is the same. You encounter the same rate, right? So if you put the blood on the scar over the scleral flap, you have the rate of scar formation. But anything go with the post and call. So if you get the patient on the hospitalize the patient and put them to the OR, you make the patient pay more, and you make more time, and you have to spend more time, and the rate is the same because when you suture again, it's the same rate.
But you can control. Yes, you can control it better. No, we should discuss about that. I see here the outcome is very good because no leaking, and then after 6 months, the outcome is still very good. No high pressure and no leakage. It means it's very good. But I would like to find out the reason you choose. Of course, when you take the patient to OR, you check the wound, you secure it by the new suture, and I'm sure that you can control that better than by bleeding. Because when we do bleeding, to make the bleeding, we cannot control that. Sometimes it's too much, sometimes it's too little. So the right amount is typical, I think that. So, because some other doctor may learn from you, so you should know more why we choose that and why we should not check, repair the conjunctival flap or scleral flap for that.
I think that's the reason I chose to use the needling with the autologous blood instead of the sutures again, because I think that the rate is the same, and the technique is much easier for you to do the patient, and even for the patient or for you is better. And as you can see, we have a range of study about they inject the whole blood into the blood, and some of them the leg is still, but half of them the leg is still not still, or it really leaking after a while. So it means that if you only put the blood into the subcutaneous space, it will disappear in a very short time. The time that you want, it means that when you put the blood over the scleral flap, you don't do any kind of minor trauma on the scleral flap. You just put the blood in on the surface.
Not in the interface.
Yeah. It's acting like a fresh pattern, but it's more directly.
Okay. Thank you. So any question? Dr. Kung, please.
Thank you very much for the very good presentation. It is a real fantastic procedure. And so I would like to could you share with us the experience about the needling techniques. Be honestly, I tried one time to do this technique for my patient who had flat legs and with the IOP not control. So I failed. It's the first time because when I inserted in the needle in the subconjunctival, I couldn't see the tip of the needle. So at that time I tried to do some insertions and pull it out because it caused the bleeding and the conjunctival edema, so I cannot see clearly about the tip of the needle. So can you share with us your experience about that? How we confirm that the aqueous flow out from the blood, and how you confirm that the needle go the right way, right direction? Yes.
You mean that I think that you mentioned about the the fell blast, right? Because you want to make the aqueous tumor to work again because your blast is fast. In this case, in kind of case, you have to evaluate whether the blast, the reason why the blast fell. The blast fell because of the scar over the flap, or the blast fell because of the scar under the flap. Or if you have to do the gonioscopy as well to see that whether the iris is blocked into the window we create when you do the chart. So it depends on the reason. So it's true the technique. We do needling, but a lot kind of needling. We needling over the spiral flap, under the conjunctiva, or if needling to under the scleral flap. You push the needling, even in the top case, you can push the needling through the under scleral flap into the AC to make the aqueous tumor to work again. I have a lot of video clip that I do the needling with a different technique. If you want, I can share with you.
Thank you very much. So I think I have to learn more about that.
Dr. Kuh's question is how to do the needling in case the blast fail, and you try to get under the flap, right, between the interface. But the problem, the conjunctiva is not clear enough and it matters, so you cannot see very well the limit of the incision, so you cannot continue, right? That's your question, and you like to ask her experience to do that. How you can do that? So can you say your experience?
In my experience, it's much easier for the starter. So the needling starter, that we begin with the really clear conjunctiva, or even put some alpha P that work like constrict the vessel, so you can see clear through it. And otherwise, when you accidentally break the conjunctival vessel and make a lot of subconjunctival hemorrhage, it becomes really difficult for you to visual what the underline. So in that case, you have to be experienced one, because if you where the needle is go, when you touch the scleral flap, the feeling is different. That's it's very difficult to describe. But if you've done maybe a lot of them, you have that feeling that you touch the scleral flap, you decided to go under this or over it.
So it means that it's difficult to describe but easy to do. So let's see if
when I clearly, when I do it, it's not clearly like that. It's very difficult to see the tip of the needle. So, but I learn more from you that the indications for the needling. Yes.
Yeah.
Thank you very much.
Oh, I saw Dr. Tân. Have you finished your surgery and come back? Yeah, so, so you speak some words and then go back to OR, please. Yeah, please, Dr. Tân.
I would like to have some comments too, because it seems to me that Dr. Kuhn has more concern about another problem than the topic of this presentation, because the topic today's presentation is how to seal the blood leakage. But Dr. Kuhn wants to ask about how to do needling for the encapsulated blood, how to tear out the fibrous membrane, the subconjunctival membrane. So first of all, I would like to have some comment about the Kuhn question first, and after that I also have some comment about the presentation. So in terms of the needling for the encapsulated blood, I think first of all we need to very good preparation, like said. We need to first of all to have a good topical anesthesia, and sometimes with a very sensitive subject, we also need some subsequent type of anesthesia like lidocaine. We inject the lidocaine around the blood filtration first. After that, we will need it later because sometimes with only the topical anesthesia, the patient will be also very painful. Patient it cannot be operated during the procedure. And the second thing to do is to do some imaging before the blood needling, because we have to know that we can do, we will be able to do needling, and that needling will work or not, because sometimes the fibrosis is so intensive, so extensive, that it seals down the scleral flap so tightly, and no no blood at all. So I think it's no reason to do needling because it's very dangerous. It can tear the conjunctiva, it can make a lot of bleeding for nothing. So you need to do you should do the imaging first before the needling, because we know that there's some blood there, but it's surrounded by the scarring tissue, and you tear away the fibrous membrane to make the blood filtration more diffuse. That's the goal of needling. And the third thing is to do the vasoconstrictor, like V.Medical, some 1 or 2 drops 15 minutes before the procedure to constrict the vessel, so that can prevent better the bleeding during the procedure. But sometimes the bleeding still happens, and so my recommendation for those situations is to keep going, and you just feel the needle under the conjunctiva, and you go under the flap. Anyway, when you do the needling under the scleral flap, you couldn't see the needle tip, so you had to feel at the finger tip. I had to do so. And as I said, sometimes you go inside the anterior chamber. So that's why I always constrict the pupil before the needling, because in case I have to go inside the anterior chamber, that can prevent the hernia of the iris, and that's also help you a lot. But sometimes you do needling and you go inside the anterior chamber, and the iris pick up, and also you fail. You seize the iris under the conjunctiva. And if the hernia of the iris happen, so my tip is that just to push again the orifice, against the opening, the side of the radiculectomy, try to push the iris inside. So when we have got some outflow, and you can push the iris inside, the iris will stay there, and you just wait for 1 or 2 minutes, and keep constrict the pupil and wait and see them. And I have some cases of hernia iris, and I push it in and get the outflow, mean that the eye becomes softer and the iris will stay inside. So luckily I didn't need to reopen the side, do the radiculectomy again, and close the scleral flap. So that all my some experience and comments about needling for the wound needling. So come back to the topic today. So maybe the word of needling here is not correct. So that's why you do the search on PubMed, you didn't see any results, because needling have a different meaning. Needling means needling, so that where we did the procedure coding together, I try to translate the word needling, because needling is such a borrowed word from English. So I try to translate, and finally I ended up with sense about begin. that's why we have a new coding for this procedure is just on the key. So that's why I think in this case, this topic, this technique is not needed because you just do some trauma, like she said, through the bleb and cause the bleeding to patch over the scleral flap and to hold down everything underneath and try to prevent the further leakage. So maybe it's not the word needling doesn't work here, not suitable work for the topic. You should try to find out another term, another word for that theme of that presentation. And so I think I didn't see any different point of doing that technique and inject the whole blood into the bleb, because when you inject, you can also inject inside the filtration area, and so that also acts like a blood patch, like the term she used in her presentation. And I also agree with Dr. Dong, Mr. Dong, that you have to pay. You do it the technique with the price, because you can fill the blood with the blood, because you will inject the blood, it can cause a lot of inflammation and cause more scarring. So that's why I think with more patients, more number of cases, you will see the failure of the blood with that technique. So don't be so sure that about the success rate, like 5 cases of 100%. I think that with the price of maybe some percentage of the failure of the blood, with more cases. So that's for the same reason. I think that you shouldn't do the technique. You shouldn't apply a technique. It's my own opinion for the early leak, because why we afraid of taking patient to OR for another time. Pride or money, it doesn't matter, because it's not very expensive for the just do the suture of the conjunctival flap. So very quick procedure and not expensive. And the benefit of doing an additional stitch is much more, and it outweighs the risk of injecting blood. Can be sure of that, because a long time ago when I was a resident, so I had a chance to work with Howard Cole, a specialist from Orbis, and his opinion is whenever you see the early leak, you have to do suture right away. Why? Because don't waste the time to wait, because without the outflow, you will not have the space, subsequent space. So the conjunctiva will stick to the sclera, and so in the future the morphology is so bad, it's very bad. So that's why he said that he argued that you can do some conservative treatment like a bandage, contact lens, suppression, and cut down the steroid treatment. But he, with his opinion, go right away to OI suture. And suture is very simple and get a lot of benefits. So maybe it's my own opinion for early leach. You shouldn't waste time to do conservative treatment and do the suture right away, and you get the bleb filtration much better.
Thank you, Dr. Tan. It also is my concern about that, because we saw that the 4 patients, they have a leakage the day 1 after the surgery. It's very early. So I think we should check the wound. If the wound is too loose, the suture is too loose, we should cover it first. Fortunately for this case, everything is okay, that's good, but I agree with you, it should not be recommended to do that. And relating to your comment, you said that before to do the needling, we should do the imaging test. So can you tell us what kind of test we should do to check the situation of the bleb?
So to check the the situation of the fistula in glaucoma, we call as fistula because we have the draining way from inside to outside.
Yes.
So first of all, we need to do the colonoscopy to see if anything blocked inside, like iris, like vitreous, or like blood clot. So it's nothing in the inner orifice. So it can be on the way out, that is subscleral flap or subconjunctival. In almost all of the cases that is scarring under the conjunctiva. So the imaging tests in glaucoma department have some studying about the morphology of the bleb. So we can use the intersegmental CT or we can use the UVM to see if any conjunctival space in that we have the area of the water or area of water collection there. So if there's some subconjunctival space, that we have some outflow, but it's stuck out there because of the scarring tissue. So that the case a very good candidate to do the needling. But for some other cases, even without subconjunctival space, but very early, normally within 2 weeks after the trachelectomy, can do. First of all, we would try to do some suture removal first, because for those cases, normally for the scleral stitches too tight. So we like to try to massage the suture removal first with some laser, or even for those cases we do a needling, but we use a needle subconjunctival place and cut the stitch and lift up a little bit the scleral flap.
Thank you. Any comment or question from audience? Dr. Benay, Dr. Nathai, do you have any comment or question?
I totally agree with Dr. Dong about the early lab leaking, because with the early case we should observe first, and we use the conservative management first, and I usually do the needling after 2 weeks, and I think the needling worst is good in this case, because before you inject the blood, you must do needling under the conjunctiva first, and then you inject the blood near the hole of the conjunctiva. And if you just inject the blood to do the patch, the scar still there, and the hematoculus creates the room there, and the leak still recurrent. So to have a good reason, you should do the needling first, and then you inject the blood. So the needling here is good worse. And with the technique, the question of Dr. Kuhn, I think the most important point is that you must recognize where the scar growing. In the under the flap, with the flat bleb, or above the scleral flap, where the flap